Hi there and welcome. My name is Dr. Craig Primack. The following you're about to watch is a video that I recorded a few weeks ago about weight loss medications. Several of the medications that I will talk about in this video are phentermine, Contrave, Saxenda, Belviq, Qsymia, and several others. Enjoy. So first of all, thanks everyone again for coming. If you haven't been here before, thanks for coming for the first time. The topic we're going to talk about tonight is weight loss medications. Most of you obviously know me. This is my passion. This is what I talk about more than I talk about anything else. There's been 4 weight loss drugs released since 2012. I've been on the Speakers Bureau for all 4 of them. I've probably talked 50, 60 times to groups of doctors about weight loss drugs. And 2 times ago when we did the one about the science part, that's kind of my second passion. The talk tonight is actually, I adapted it. I actually gave it to about 1,000 medical people back in September at Camelback Inn. And I changed a few of the words here and there to make it good for all of us. Instead of using as much doctor speak, but I'll talk you through the doctor words and so forth there. And so let's get going. First, I just have a little agenda. I did release a book, which we'll talk about. We do have a book signing event coming up. I do have a blog, which videos like this are now appearing on, if you haven't heard about it yet. Tonight's big topic, weight loss medications and what we're about them. If you remember, I always like to talk about something scientific and then something to take home. What can I learn? What can I do? What can I be a better person besides just the science part? So that's about living a long and healthy life. And we're going to learn a little bit about blue zones. If you've heard about blue zones, there's 5 areas of the world that they've identified people that live statistically more than 100 years old, and we can learn from them. We have to move there to, I think, truly adapt to what they do, but there are things I think we can take away from that we can all do. And then the next one I've already scheduled, Thursday, March 28th. The week after that, since I like to, I call it practice on you guys, the last talk I gave was about malpractice. And so the week after I gave it at a big talk. And so the next one will be about sleep and how it affects weight. And then all the other things that I'm learning very quickly is diabetes, heart disease, Alzheimer's. And I've always been excited about it for weight, but now it's all these other things too. And that will also be kind of the scientific side, but then the how can I sleep better side, which I think we all need. Just to talk about this disease itself or the problem itself doesn't help us unless we have somewhat of a solution. So that is the book, Chasing Diet. So download it, read it, enjoy it. It was a labor of love by Dr. Ziltzer and myself over the last, I don't know, probably since May when we started writing it. So it's really about what we do and why we do what we do. Yeah.
You don't have to have or use a Kindle as well. You can download the Kindle app for free on your phone. And then if you go to the link that they posted, it'll download it straight to your Kindle so you can have it on your phone as well.
Yeah, so your phone or an iPad or any kind of, I even think laptops, if you go and download the Kindle app, which is a free app, you can then go into the Amazon store and download it. It's exciting that we are doing a book signing at the Barnes & Noble right over here at 90th and Shea. You're all welcome. So it's Wednesday, February 6th at 6:30. This is the big sign as you walk in Barnes & Noble. This is the sign, I think, in the doorway. That's kind of neat. And Dr. Ziltzer and I will be, we're talking about something for only 10 or 15 minutes. So. And then the question is, are you social? So I've become social. drprimack.com is my blog. Pretty original, had to come up with it. No, just kidding. But I have put, the first 2 talks ended up with 2 videos apiece, so I put both of those on there. I have a personal recipe on how to make a chocolate bar, which I've told some of you guys, but the best way of a chocolate bar with, if you like peanut butter with PB2 on top and then the microwave, that is the latest video that went up, I think, on Monday or over the weekend. This one hopefully will be up there by next week also. Instagram, if anyone does Instagram, Facebook, I do have a Facebook doctor page. We do have a Twitter and we do have a LinkedIn. But I think even more important than that, Scottsdale Weight Loss Center itself has a Facebook page. And for anyone who's a patient, we have a private Facebook, only for patients. I think sometimes we talk about it, but I think sometimes Some people have been patients for a long time and never heard about it. If you're ever on Facebook, you go to, it's a funky thing, the Village with the @ sign, Scottsdale Weight Loss, and you tell it who your doctor is, and then they sign you in. And so it's only people that we take care of. So all 4 offices. Good. So let's kind of get started. This is what we call the 4 pillars of weight loss. A lot of people will talk about it, and I talked about it before. This is the chair. There are 4 legs of everyone's chair. If you go on one leg, and everyone's seen that kid back in high school who balanced on the one leg of the chair, and what happened? He fell over. So it's January. The number one thing, and we already talked about what happens in January, people start going to gyms, right? And that's what I'm going to do. I'm going to lose weight. I'm going to go to the gym. And what happens in February? Have they lost weight? Not really. No. And so one aspect is exercise of some type. The second aspect is nutrition and diet. The third aspect is, as we say, behavior. Changing what you do, figuring out what your triggers are, why I stress eat if I stress eat, why I bored to eat, why I tired to eat, and all those kind of things. And the last is medications. And so that's the leg of the chair we're going to talk about today. When you put all 4 legs strongly on the ground, and then I say stress comes in and we rock your chair. So we all have stress. We all have some level of stress. And it comes in, rocks your chair. Your stable ground keeps you better than if you had less pieces of the puzzle. So that's the philosophy behind that. There's a big algorithm. It's now over 300 pages that I was one of the authors of. It's called the obesityalgorithm.org. Anyone can download it if you want. I don't know that I recommend downloading it at that many things. It is doctor, but if you're interested in kind of the high level stuff, that's it. And we talk a lot. I mean, there's probably 75 pages of the 300 about weight loss medications. When you really start to talk about it, so our society now, we call weight a disease. And the reason we call it a disease, I'll get into. But if it was a personal choice, you could just push, as we all know, it's not just pushing the food away and being a little more active. If that were the case, none of us would be here. Data collection, so doctors talk to our patients. We take measurements, we get on fancy scales like we have. We sit down at our first evaluation and then we talk about what's happened before, where your weight is from where you started, do you work out, are you on medicines, all those kind of things. Then we make decisions based on these 4, and we added one more, bariatric procedure. So nutritional intervention, some kind of diet. Physical activity, being active, which you'll hear time and time again, unfortunately, in the literatures, they say, be more active. And I think that's a misnomer. I think a lot of people are active enough. I have people that run marathons. It doesn't make their weight normal. I wouldn't say run more marathons. I mean, how much can you do? So I think the word is adequate exercise to feel good. Behavior therapy, pharmacotherapy, again, our topic today. And then there are bariatric procedures. And I think you just have to be careful about your bariatric procedures. There's new and unproven ones, and there's really good ones that have been around for a while. Unfortunately, one of my patients who I had been taking care of for a while stopped coming into clinic. I saw her again this last week. She went in and had these balloons placed in her stomach, and she has lost 10 pounds net, unfortunately, since August. And so you have to be careful at the proven things. Although there are some bariatric procedures that are very good, that being said. Principles. Why do we even think about using weight loss drugs? Because this is a serious and chronic disease. Serious means it causes health problems. If we do nothing about our weight over time, it will cause problems. And we can name all those things. Blood pressure is higher, cholesterol is higher, joint problems, sleep apnea, cancers, all of them. And then chronic is, it doesn't just go away. It's not a sinus infection. We don't treat it with an antibiotic for 2 weeks, and then all of a sudden we're thin. Unfortunately, back in the 1950s, and we're gonna talk a little bit about the 1950s, when the weight loss drugs first came out, that was the belief. You treat something short, 3 months, and then we're all normal after that. That wasn't the case. They actually did some studies on the opposite. They force-fed people. They made them gain 40, 50 pounds. And then they said, well, now that you've gained the weight, and that didn't happen either. You didn't keep the weight. Those people, because they were naturally what they were normal doing their normal lives, they lost all that weight again for the same reason. Medications, as a consideration, should be prescribed chronically, meaning I'm not going to just do this for 3 weeks or 4 weeks and then stop them. because when we, please, welcome. When we stop them, what happens? Weight goes back. So a lot of people say that's a failing of weight loss drugs. But is it? Think about some of the other medicines we use. Blood pressure medicines, cholesterol medicines. We know when we're taking our blood pressure medicine, what happens? Our blood pressure is good. We go to our doctor and they say, you know what, your blood pressure is good. Stay on what you're staying. You come back and see them in a couple months, and what do they say? You're doing great. Stay on your blood pressure medicine. A couple months later, what do they say? Stay on your blood pressure medicine. When we stop our blood pressure medicine, the next day we go into our doctor, and where's our blood pressure? It's high. Our cholesterol, it's high. And so the fact that we have to use these medicines for a long time is no different than any other chronic disease. But why people think that, I'm still not understanding. They're not really just appetite suppressants, so that is probably the main indication we use them. Some of them also help metabolism. Some of them work on the body's regulation of weight piece. They are not, when the FDA studies, or when companies study them and the FDA approves them, they're not approving them for appetite suppression. They're approving them for weight management. That is their indication. And I talked about antihypertensives. They are suggested to be used when or with diet and adequate exercise. That is when we should be thinking about using them in someone who's been unsuccessful in losing weight on their own. The average person we now know is trying to lose weight 2.5 times every couple years, and they're unsuccessful when done on their own. And so that person is, number one, a candidate. When you're unable to maintain your weight loss. So a lot of people can lose weight just fine. And then what happens? Goes back up. Sometimes we call it the Nike swoosh. Comes down, goes back up, comes down. And so to help maintain your weight, even if you don't use it in the beginning, you can use weight loss drugs later. And then the last, who meet labeled indications. So the FDA has put out some guidelines on who and when we should use these. So that's what we'll talk about next. So the FDA has guidelines for the last several years. This is when weight loss drugs should be used. So they say people with a BMI greater than 30, people with a BMI greater than 27 who have other risk factors. So I call this is like staging the disease. We stage diseases and cancers, they give it staged all the time. So if your weight is BMI of 30 or above, it's enough disease to start using medications. If it's 27 with blood pressure or cholesterol or sleep apnea or any, we've listed 3. So diabetes, hypertension, and cholesterol problems, but it's not the only ones. And then I think the other piece, and that's where it starts to be an art and not only an FDA science, is a lot of people know that BMI is a lousy measure of what our weight is doing. If you remember back, Arnold Schwarzenegger is always the example everyone will use in their thing. Back in the day when he was Conan the Barbarian, his BMI was 33 or 34. Falls way above the 30 line. And how much body fat did he have? Probably 1 or 2%, if that. Now he did use steroids. It's a whole nother thing, which wasn't good for his probable health overall. But that being said, he would not be someone who we would consider has problems. The other opposite, and I see it every day in the clinic as we put people on our fancy Tanita scale, is someone has a BMI of 24.9 or 26 or something, but their body fat is enough that they fall into these categories. So we use body fat just as much as we use BMI. So let's talk about drugs. Has anyone tried Orlistat, Xenical, Ally in the past? Heard of it? So back before 2012, there were only 2 drugs on the market for many years for weight. This was one of them. The other one has come off the market. So it started out as Orlistat or Xenical. Xenical was the brand name. And then they made it over the counter. You can buy this still, I think, probably even at Costco for a while, called Ally. What does it do? It's a lipase inhibitor. Anybody know what a lipase inhibitor is? It blocks the absorption of fat. And so they said as you eat fat, about 30% of the fat that we eat, which has a lot of calories, 9 calories per gram, doesn't get absorbed, and you pass it out. So if you eat a lot of it, you pass a lot of it. If you don't eat a lot of it, the problem was if you didn't eat fat, now I was eating more carbohydrates. We know eating carbohydrates is not good either. And so this is not the best of all medications. It wasn't very successful for most people. It was 120 milligrams 3 times a day, to do it. And then when they made it over the counter, all they did is drop the dose in half. And they sold millions of this drug. And I still remember one of the first people, so when I started this, it was 2003 or 2004. So we only had really 2 tools that we used commonly, this one and the one that went off the market. And so I put a woman on this. She was working in an office. She was in her 60s. And that happens when you have fat that you don't absorb and now you pass. The medical word is called steatorrhea, but I will tell you that is greasy diarrhea. Oh. And you can't sometimes tell if you're passing gas or passing this. And she worked in an office, and you can just say she had to go home and change her clothes. And again, who would ever take this drug a second time? Never took it again. I don't know that I prescribed it more than 1 or 2 other times after those kind of incidents. Never prescribed it much anyway, but we didn't have a lot of tools. So we used those, and the other was obviously gas. So this drug is still available, but never been something that was a good answer. 1959 was a big drug. I probably already mentioned the 1950s. Happy birthday this year, 60 years loved. What is it? What's the drug? Phentermine. Oop, there it is, phentermine. Absolutely. One of the first weight loss drugs on the market. The only problem at the time was it was not known about weight. It was known about the drug. It's still the #1 prescribed drug in the United States, by far. It's a sympathomimetic. It mimics or is a mild stimulant, and it works on the hypothalamus. Hypothalamus is the culprit in our weight problem. It's about the size of a blueberry. It sits in the center of our brain, and it regulates our hunger. In the thousands of years humans have been around, when there's been famine, and there's been a lot of famine, minus the last, industrialized times, last 120 years-ish, although there's still parts, obviously, of the world that have that. When we had a famine, the hypothalamus was very good. It turned our metabolism down, which we all know happens, and turned our hunger up. So we hunted, we gathered, and we lasted longer because our metabolism was slower. And our body can't tell the difference between famine and diet. Essentially, we're giving it less food, it doesn't know the difference. And so this is working directly on the hypothalamus to stimulate it, to decrease our appetite that we can measure by hormones is changing. The dose, as you know, for many of you who are on it, it starts as a 37.5 milligram size tablet. Most people will start with a half a tablet. We'll either work to 2 half tablets is what I really like, about 3 to 4 hours apart. Sometimes going up to a full tablet. It comes in a few other strengths we don't see very often, but they are available. There's an 8 milligram short release that you can take up to 3 times a day. There's a 15 milligram and a 30 milligram. 37.5 seems to work well. If you break the half, it's pretty close to the 15. It is a mild stimulant, so biggest side effect, a little sleeplessness, especially the first 3 nights. If you've heard me talk about it, I always say you'll have a little problem sleeping potentially for the first 3 nights, and then after that you'll sleep as well or as lousy as you currently do, because we don't sleep as a society any longer. And 95% of people who take this drug after 3 nights can sleep just as well or as lousy as they used to. Because it does increase metabolism a little bit, we are cautioned with active heart disease. That CAD is coronary artery disease. So if you have active going on, angina and things like that, where your doctor's looking at your heart, we are cautious with it. Sometimes we use it in people who've had other heart problems, sometimes we don't, but we always run it by the cardiologist and clear those kind of things. That's really the biggest thing that we watch for with this. It is a scheduled or controlled drug. What does that mean? The FDA watches it, and you can only prescribe it certain ways for certain amounts of time, and so forth. Approved in 1959, as we talked about. The label said use it for 12 weeks. I have another slide that we'll talk about here. Use it for 12 weeks and then stop. Hopefully none of us move to the state of Ohio. In Ohio, that is actually still the law. And our society has been trying to fight that since I've been a member since 2005. I think we've been fighting it since then. But in the state of Ohio, if you have phentermine, you can take it for 12 weeks in a lifetime. And that's it. And so don't move to Ohio. And we'll talk a little bit more about that as we go on. So that's phentermine. Lorcaserin or Belviq. This was one of the next ones to hit the market, 2012. It is a selective serotonin 2C agonist. That's a lot of words to back up. So who remembers fen-phen? So fen-phen was a combination of two drugs. Phentermine, the one we just talked about, and a drug called fenfluramine. Fenfluramine did two things. It was really good working on the brain to decrease appetite. When you put it with phentermine, it was very good. But it also worked on the heart to cause some thickening in heart valves. People needed valve replacements and such, and so it was taken off the market. It's never coming back. We knew that it worked really well on the brain, so they found a molecule that worked on the brain, but not on the heart. So that's what this is. It's almost like a heart healthy, you put it with phentermine, almost like a heart, what we call a heart healthy fen-phen. And so it increases satiety, it increases fullness. That's its job. It is not a stimulant at all. So it's good for a lot of people who either have insomnia or have other heart problems. Very safe in that. It's well tolerated. In my experience, if anyone has any side effect to this drug, it's a headache on the first day, and I think it's less than 10%. I don't think I've seen almost anything else. 99% for sure of the people I've prescribed it for have tolerated the drug quite well. Controls appetite without raising blood pressure, causing anxiety or insomnia, which in a very small percent phentermine can do. It comes in two forms. It came out initially as a 10 milligram twice a day drug, and then a 20 milligram once a day drug. I've had people on both. If it works in you, it may work in both. I think, and this is only my experience, some people tend to do better on the twice a day than the once a day drug, but I haven't had enough people kind of try both, so to speak. To be sure. It's an interesting one because it also decreases hemoglobin A1C. Hemoglobin A1C is how we monitor diabetes. It's doing something more than just weight loss for our blood sugar. We don't know what that mechanism is, but if your weight goes down, call it 10%, we expect some other things to come down, the same amount, but we're seeing the blood sugar and the diabetes get even better than we'd expect by the amount of weight loss. So that's obviously one of the benefits that we would try this drug for in someone who has diabetes. And then all the drugs, and we'll talk about the other three in a second, that have come out since 2012, because of fenfluramine, that bad drug, they've come out and said we need to prove that this is heart healthy. So not only do you do a study showing it has weight loss, but we need another study showing heart health. And so they're the first of the four to publish something called a CVOT, or cardiovascular outcomes trial. So basically doing a study of weight loss, but really looking specifically at the heart to see if it is safe. So if you remember also, fenfluramine had heart valve problems. When they did the initial studies of Belviq, they did 30,000 or so echocardiograms on people's hearts as they were taking the drug in the study, and they did not see any problems. Then they came out with this other study, the cardiovascular outcomes trial. There's not a heart problem that we see. Possible interactions with other drugs that affect serotonin. So primary care doctors, and they've talked about, oh my gosh, this is a serotonin type drug. All the antidepressants typically we use, Prozac, Zoloft, all those are serotonin drugs. So we're going to have a problem when you put these both together. The problem, if it was there, would be called something called serotonin syndrome. Serotonin syndrome, if you think of something that calms you, serotonin syndrome would be the exact opposite. Your blood pressure would be high, you would feel hot, your heart would be fast, you'd be irritable, you wouldn't sleep, all those things. And so we started in the first year watching for that, didn't see it at all. And then I had people run high doses of other serotonin drugs, and I would call their psychiatrist and I'd say, I'm thinking of putting them on this, what do you think? They, interestingly enough, were never afraid of serotonin syndrome. And so my experience is now, since 2012, 2019, that if you're on what I call standard doses of serotonin drugs, if you're on a Prozac at 20 milligrams or a Zoloft at 50 or something like that, I have not seen any interaction with this type of drug. And we've pushed the dose higher on those, or some people are on, and we watch them closely. The psychiatrist watches from their side, I watch from my side. We haven't seen any serotonin syndrome yet. Can't say it doesn't happen, but we haven't, and I've used a fair amount of this drug with patients. It is also a Schedule 4 control drug, and then it is, as we talk about, it is more moderately priced. It's somewhere in the $80 range for most people. I've had a few insurances that cover it at $25 or $30 or $5, but most of the time it's in that range. And then, as we said, it was approved in 2012. Questions?
Can you go back to the migraine meds?
Yes.
What issues?
So with some of the migraine meds, they are serotonin type drugs, the Zomigs and that style. And so if you take a lot of those at the same time you're taking that, there is the potential for serotonin syndrome. Again, I haven't seen it. The goal, I think, for migraines is to take less of those kind of migraine meds than more. Phentermine with topiramate extended release. So phentermine and Topamax. It did initially come out as a drug, or it is out as a drug called Qsymia in one pill. But as you know here, we combine the two separate pills all the time. So we can titrate the two doses separately. So it comes as a fixed sympathomimetic or mild stimulant in phentermine and the effect on the hypothalamus. And then topiramate. Topiramate came out when we talk about migraines. Topiramate came out 20 years ago, I believe, as a anti-seizure drug. It wasn't any better or worse than the ones that are on the market, so it never took off. Somewhere someone figured out that it actually prevents migraines. So of medication that prevents migraines, it's the #1 most commonly used. When they were studying it, I believe, for migraines, they said, oh my gosh, the people on the drug are losing weight, people not on the drug are not losing weight, there must be a weight loss piece there. And so they studied it initially just as a weight loss drug. They did a 6-month study, and placebo or not, so on the drug or on the fake drug, and they lost weight, 6 or 8% of their weight. Then they did a 2-year study to prove that it worked, and yes, it continued on for 2 years. They did a study where you had to lose 8% of your weight first, just diet, and then you went on the drug or the placebo. The people on the drug continued to lose weight additionally, and the people on the placebo started to gain their weight back. And then they started combining with phentermine, and they've done a lot of studies. The way the FDA in 2012 or ish likes to see studies, and it is a good combination of medications. Benefits: it is the most potent weight loss drug combination that has been studied. We'll talk about that. That isn't for everybody, but for more people than not, it is the strongest combination. It's a great option for people who want 1 pill per day because it's only 1 in the morning. It's generally well tolerated. The dose of phentermine is a little bit lower than what we do. It's basically what we would use as a half of phentermine as the top dose. But we start at very, very low. The phentermine starts at 3.75 milligrams, which is like licking a normal phentermine pill, really. And 23 of the topiramate or Topamax. Then it goes up to 77.5, and that's what they call kind of the standard dose. So most people will go there and they'll be on it for a while. If they don't keep losing weight or enough weight after 12 weeks, they go up to a titration dose, which is now only 11.25, and then the next dose, which is called a top dose, of 15 milligrams of phentermine and 92 of topiramate. Of the topiramate we use here, it's a 50 milligrams, so a half of one would be 25 milligrams, a full tablet would be 50, 2 full ones would be 100. So it's pretty equivalent dosing. There is a requirement that came out, interestingly enough, for Qsymia of this term that they now call FORP, females of reproductive potential. So women who can get pregnant need to do pregnancy testing or have 2 forms of birth control while on this. Now it's an interesting thing by the FDA because it's because of topiramate. And if you're on topiramate for seizures or headaches, which is a different part of the FDA, there's no pregnancy testing, no recommendation because it's a disease. And then it comes to weights, and we change the requirements, and we have to do this extra testing. And so it was a little problem, obviously. When it first came out, the FDA tracked physicians who were writing it all the time. They tried to train us differently. It softened a little bit, but it's still a recommendation that we follow. It is moderately expensive. For most people, unfortunately, it's about $200 to $230 a month. And so the separate ones are significantly less expensive. It's approved 2012, as we talked about, and we can do generic or off-label Qsymia by combining the 2 drugs. It is Schedule 4 controlled because of the phentermine in there. Questions?
Do you use short-acting topiramate?
So we usually do short-acting topiramate, but we dose it twice a day. There is some long-acting ones, which I guess we can use. I haven't found much need for it. Bupropion extended release with Naltrexon or Contrave. One of the ones we tend to use a fair amount, a lot of. This is an interesting drug. So it's a combination of 2 medicines. but it decreases cravings by blocking two parts of the brain. One part is the same hypothalamus that we been talking about before, but then there's a whole part of the brain called the reward center. When we're look at that food and we're like, I'm not really hungry, but that dessert looks really good. That's this part of the brain that it's working on. So this drug, I think 100% of the time, this is a cravings drug, which is interesting. So benefits, 24-hour a day appetite, hunger, and cravings controller. They did some interesting in the studies besides the weight loss, they did some studies or questionnaires on cravings. And if you had a lot of cravings for certain foods and you took this, the cravings, as you measured it later on, the cravings went down, which was nice. It's very different effect from other medications that work just on the hypothalamus. So it's good in that sense. Moderately priced. If your insurance doesn't cover it, and most don't, 4-week titration. You take 1 pill in the morning for the first week. You take 1 pill in the morning and a second at 5 p.m. in the second week. So the two medicines in this, Bupropion ER is Wellbutrin. Wellbutrin is a medicine that, as an antidepressant, that's been out for a long time. Some people who take that one too close to bed have trouble falling asleep. And so that's why the 5 p.m. dose is there. I tell most people, aim for 5 p.m. You're gonna forget one day. On that one day you forget, take it right before bed. If you have trouble falling asleep that night, we know you have to take it at 5 p.m. If you have no trouble, just take it right before bed and so forth. Interesting enough, so bupropion is also used for smoking cessation. So Zyban, if you've heard the name Zyban. Naltrexon is used for alcohol cessation. And so you kind of put the smoking and the alcohol one together and we get food, which I think is really, it is a craving or an addiction at some level, just the same. Generally well tolerated. It can cause nausea, and that's probably the most side effect. The naltrexone, and the reason we start slow and build it up over 4 weeks is because of nausea. There are a few people that with the first dose, they've had really significant nausea. I have not been able to get them on the drug. Some people take it for 2 or 3 days, they'll feel a little queasy. I can then back the dose off, and maybe we go every other day, we go every third day for a week or two, and then we slowly build it up over, instead of a month, we build it up over 6 weeks, 8 weeks, even 3 months, and we can get them successfully on this drug, which is nice. If you have other seizure things, bupropion, the Wellbutrin decreases seizure threshold. So if you had a tendency, it's only come up one time, I think, since it's been out. So the biggest thing, and it's one of the reasons we wouldn't use it, is because it cannot be used with opioids. Naltrexone is an anti-opioid drug. So opioids are pain medicines like Vicodin and Percocet and codeine and such. And so people who have chronic pain can't use this because it blocks that. If you were on it and you had to have, I say you have back pain and you had to have knee surgery, we stop the drug. When it's out of your system for about 48 hours, you can then take pain medicine. When the pain medicine is out of your system for 48 hours, you can go back on your Contrave. And so it hasn't stopped anyone from using it who doesn't use it if they don't use pain medicine on a chronic basis. Approved in 2014, but really came out in 2015. So we've only had 3 or 4 years of experience with the combination. I have tried we'll call it the separate combination, because they're 2 different drugs. I haven't found it to work quite as well as the one pill together. I'm not exactly sure. It may be the extended release part of the naltrexone also, so it's a little bit longer. And the nice thing, it's not a controlled substance. The FDA doesn't follow that one at all. Questions? Liraglutide 3.0 milligrams or Saxenda. So this is one of the newer, most now kind of growing really quickly drugs. It is a GLP-1 agonist. Anyone know? No, I'm just kidding. So we have a hormone that comes from our small intestine called GLP-1. It goes through the blood to the hypothalamus and some other areas of the brain and says, I'm full. So as the food gets there and it keeps sending more signals, the half-life of the signal that you and I all have at some level only lasts 2 or 3 minutes. And this drug, the half-life is 13 hours. And so it's causing it to be full longer. So it actually is also, some people are on a medicine called Victoza. So this is basically high-dose Victoza. Victoza is at 1.2 to 1.8 milligrams, so it's used for diabetes. pre-diabetes. And when you go up to 3 milligrams, then it's used for weight. You don't have to have any diabetes at all. Its benefits, it is long-acting appetite control. So it's a 24-hour-a-day drug. You put it in the morning. It's not like, you know, when I talk about long-acting, so phentermine, we need to come up in the daytime, but we need it to go down as it's a stimulant so we can all sleep in the night. So the last couple hours of the night, if that's when your cravings and your hunger happen, phentermine is not going to be there to help us. Medicine like this achieves steady state after about 4 or 5 days, and then it's always on board. Extra benefit in those with diabetes, obviously, because it's used at smaller doses for diabetes. Considerations, you build it up over several weeks. This does have significant nausea in about 1 out of 3 people. And it has heartburn that goes along with it in some people. It slows the stomach's emptying as a side effect. It causes a little constipation in some people also. Again, with titration over 0.6 the first week, then 1.2, 1.8, 2.4, and then 3 milligrams, so that's over 5 weeks. We can slow that down also and go over more weeks. And again, I haven't had anyone really who can't take this. And that Contrave we talked about, I've had a few people first dose, it's just not for me. This one, we start really small. So if I've showed anyone the pen has these little click noises, and 10 clicks equals to 0.6, and 10 more, and so forth. So I put people on 2 clicks and 3 clicks, so a tenth of, 0.2 of the dose, 0.3 of the dose to start out with, and they seem to tolerate it fine if we go up really slow. We talked about the side effects. They are watching this whole class of drugs, although there has not been any signal in humans, although we saw it in rats and mice. Humans, remember, we are not big mice or rats. They saw something called medullary thyroid carcinoma, or MEN2, and potential pancreatitis. So if you've had pancreatitis or you have a family history of medullary thyroid carcinoma, they say do not take this. The pancreatitis happens probably from gallstones, although we haven't proven that. In the study, 12 people had pancreatitis, 6 of them had gallstones that were found. So as people don't eat, your gallbladder doesn't squeeze. When your gallbladder doesn't squeeze, it causes more gallstones. And so it's a precaution at this point. There has been history, I think since 2009 or 10, on GLP-1 drugs, and I don't think we've ever seen a case of medullary thyroid carcinoma. And so I talk about the other competitors in the space, which are used for diabetes, and those are okay for weight, but when you look at weight, the liraglutide is the strongest one that works on weight. Very, very expensive, and that's the biggest precaution, or not precaution, the biggest problem with this drug. At full price, it's $1,250 a month. For $1,250, we can do a lot of other things for that. If insurance covers it, and that's been my biggest concern or problem with this. Jamie here in my office, probably 3 a week, she's putting in prior authorizations to get this covered. And I think if I have to guess, it's 1 out of 8 to 1 out of 10 people in Arizona who can get this covered. It all has to do not on your insurance, it's not United or Blue Cross Blue Shield, it's who the employer is and if they've checked the box for weight loss drugs, and most have not in Arizona. It's a healthcare problem, not a thing problem. If it is a subcutaneous injection, which I guess I didn't say, it is the tiniest little 32, if anyone knows the needles, 32 gauge is about, it looks like your hair or 2 hairs together. If I pinch myself, this hurts more than this tiny little needle does. It's pretty easy. And then it was also approved in 2015. The next weight loss drug that hits the market from now, it's probably in 2021 or 2022. It is a drug that's related to this one. Today it's called Ozempic, and it's a once a week diabetes drug at high doses, much like this is a diabetes drug at low doses. It will be the next weight loss drug, I believe, that hits the market. They're in the studies right now to prove it's also a weight loss drug. Other medicines that we use that are not directly approved for weight. So we use a lot of ones that help with weight but may not be directly approved. The first one, and probably the most common one I use, is metformin extended release. Metformin's been out for, again, over 20 years as a diabetes drug. It's the #1 diabetes drug across the world, I would guess. they found it worked in diabetes very well. So they did some studies and said, well, does it work in pre-diabetes? Can we prevent diabetes? And so they started putting people on it for that. I don't know if it was the primary study or later on studies. They started studying teenagers who have weight problems, who have no sugar or diabetes problems at all. Does it work as a weight loss drug? And the answer was yes, it actually worked pretty well. And so if we study something on, I say on kids, and it works well, we should be able to use it in anyone, and now we do. Only about 2 or 3 years ago, we figured out one of the mechanisms that is working on weight is through that same GLP-1 mechanism that we talked about on the last drug. So it is amplifying our natural GLP-1 signal at higher doses. And so what my experience is you have to get up to at least 1,500 milligrams per day of this drug, so 750 milligrams. One doesn't seem to do enough, and the max dose is about 2,000, so we're close. I haven't found much benefit from going from the 1,500 to the 2,000 per se. Topamax, so by itself, through the Qsymia studies and such, Topamax was studied several times by itself as a weight loss drug, and it is actually very good. I have a lot of people, for whatever reason, we've chosen to just use Topamax, and Topamax works very well as a weight loss drug, even though it's that seizure and headache drug, or what it was indicated for. Tenuate. Tenuate came out in 1959 like phentermine. It's a cousin of phentermine. It's a short-acting relative. So it only lasts about 4 hours in its 25 milligram form. It doesn't have as much stimulation. It doesn't have as much insomnia. It's just a milder drug. And as you'll see on a slide coming up, the weight loss is pretty close. It comes, so you can also dose it 3 times a day throughout the day. I have some people that call it the going out to dinner pill. So they don't take anything during the day, and 5 o'clock comes and oh my gosh, we're going out to dinner tonight. Let's take a short acting 4-hour pill. It gets you through the dinner hour. It wears off before you go to sleep. Very clean and nice. For people who tolerate it well, who are using the 3 pills all the time, which is the kind of the maximum for most people, there is a 75 milligram extended release, which you can get. Phendimetrazine is another stimulant like phentermine. It came out again the same year. 1959 was a big year for weight loss drugs. So 3 of them came out, actually 3 or 4 came out that year. So this is another one. This is a different feeling for a lot of people than phentermine. I have a few people that take it who it's been the best drug they've ever taken. I've tried it on a lot more people, and they try it for a month and go, you know, the phentermine was better. So I do try it sometimes in people, but it's not been the winner, so to speak. It comes as a 35 milligram, which you can take 3 times a day, much like you would take the Tenuate, that's 25. Or you can take 105 milligrams once a day. And so I usually start the 35 up to 3 times a day, and if people are taking it 3 times, I'll go to the once a day, 105. The 105 is just 3 of the 35s together. Other GLP-1s do have some weight loss decreasing effect. So the other big ones, so the Victoza, as we talked about, has some weight loss benefit. Bidurion is a once a week GLP-1 also, and there's 2 or 3 more on the market. I don't think it was important to list all of them, but they're all GLP-1 drugs. We're seeing a little benefit in a drug class called SGLT2. SGLT2 are drugs that are taken for diabetes that about 50 grams of carbohydrates that you eat each day is actually just urinated out. So you eat it so it brings your blood sugar down and you get rid of it that way. It's interesting, the combination of a GLP-1 and an SGLT2 drug is actually pretty decent for weight loss. But the 2 together, if you don't have insurance to cover them, are ungodly expensive. I think one is $600 to $900 and the other is another $900. So Medicare is the hardest thing to get these kind of drugs for. There aren't a lot of drugs or a lot of Medicare that takes coupons that we can use in other commercial insurance. Probably the last one to talk about is Vyvanse. Vyvanse is a stimulant used in things like ADD and such, but it's also used in BED, binge eating disorder. So it's been approved specifically for binging, especially in the evening. It's eating a large quantity of food it's not a scoop of ice cream, it's an ice cream container on more than 2 nights a week for probably more than 2 or 3 weeks at a time. And so it helps with that. It's kind of a long-acting, mild onset, mild offset drug. Any other drugs people have questions on that they've seen used for weight? or that was all that came off my list when I was putting it together. So let's talk about weight loss. So what do you get with these drugs? So that was all of them. So this is a weight loss graph and pounds of weight loss above placebo. So if you took nothing, we call that 0, and then this was above that. And so phentermine in the studies way back in the 60s gave about 8 pounds. Now these are not with strong diets, this is not with exercise, this is just that. So that's why we put all these pieces together. When you look at what the drugs did in these studies and you look at what we get here at Scottsdale Weight Loss with meal replacements, with exercise, with sleep and so forth, we knock any of those studies out of the water. So you have to take this all into compared to the other drugs. Tenuate, as we see, is 6.5, 7 pounds. So even though it's a milder, it doesn't cause the stimulation that phentermine does, it's still pretty good weight loss drug. Interestingly enough, unfortunately, in controlled studies, when you're doing it in a research situation, Xenical is about the same. That's that one that nobody takes. The problem is no one takes it. Qsymia, the one I said is the most potent, look how high those go. And that's the 2 different doses, the lower dose and the higher dose. So that, you know, if we can tolerate it for more people than not, that is obviously a really good combination together. Belviq, a little bit better than these. Contrave, still up there. This is an interesting study that the Contrave people did. So they did all the studies basically for diet, do 500 calories less than their normal intake and 30 minutes of exercise 5 days a week. It's kind of a vanilla diet, vanilla exercise. They did intensive behavior modification, much like the classes we do here. And they did it twice a week in the beginning, and then it went to once a month after that. And they just, for the classes, got a significant more amount of weight loss, which we'll talk about why the benefit of classes, but that is the benefit of classes. Learning what our triggers are, learning how to go to restaurants, things like that. And then the last one was Saxenda, which falls in that same category here. With all these, and under the right circumstances, we do combine medications all together. Those have not been studied in a combined form. Phentermine is combined with many of the drugs that we've talked about here in the right person for the right reasons. Not only does the FDA look at how much average weight loss they have, they want to know of the whole group of people that took it, how many percent lost 5% of their weight, which kind of starts the medical benefits of weight loss. How many lose 10% of their weight, which is somewhere in the middle of helping diabetes, of helping blood pressure and all those things. And so this was Qsymia at the higher dose versus the I think that's switched actually. Oh yeah, Qsymia 7.5 and 15. Belviq, Contrave, and so they're all about the same, which was good in that. The FDA, when they approve a weight loss drug, they want to know how much average weight loss you have, and then also how many people are getting that 5% and how many people are getting the 10%. And I have a slide that gets into that, just a little bit of the why. So I have some case studies. I actually took these from a friend, and I'm going to talk you through them because there's a lot of medical jargon, and it just talks about, in this particular patient, what is some things that we think about as we're going through. So this was a 38-year-old female with a BMI of 31, so she has over 30 BMI, type 2 diabetes, hypertension, high blood pressure, insomnia, so that's an important piece in here, in drugs that may cause insomnia, with metformin, glimepiride, which is a diabetes drug that I don't recommend for most people, atenolol, hydrochlorothiazide, a water pill, and amitriptyline. Amitriptyline is used as a sleep aid, it's used as a pain controller, and it causes weight gain. We know that. She wasn't on contraceptives. She had no insurance coverage for the word in the doctors use is anti-obesity medications, and which this is a typical Arizona person who doesn't have coverage. Her hemoglobin A1C was 7.0. So if someone has diabetes, we want it below 6 for sure. Between 6 and 7 we say is controlled. Over 7 we say is not. So she's right on the borderline. And when you put classes or grades on her weight, it's class 1. And so her best option, 1, was phentermine. Why is phentermine? It's long acting. It may aggravate her insomnia, especially in the first 3 days, but if we can get her past that, it's a very good drug for her. Diethylpropion is actually tenuate, so that's the trade name of it. So it's low stimulation, shorter half-life, wouldn't interfere with her weight, so another good choice for her. Lorcaserin Belviq, the one we talked about. It's not stimulating. It doesn't raise her blood pressure or her heart rate. Good hemoglobin A1C reduction, so it helps her diabetes more than the weight loss. But it is more expensive, so we have to think about it that way. Bupropion ER Naltrexon is the Contrave. When I gave this talk, and you give it to doctors in a CME setting, continuing medical education, you can't use trade names. So you have to use all these other names. It may raise blood pressure mildly, but may make insomnia worse, and it is, again, more expensive, much like the Lorcaserin. Other options that are something that kind of in the back of your mind, you think of the phentermine with topiramate. So that's the Qsymia. It has good weight loss, as we've talked about. Less stimulation than phentermine, high dose by itself, but it's definitely expensive, and she doesn't have coverage for that. Liraglutide 3.0, again, is another good one for her diabetes control, but at $1,250 a month, she's never gonna get this one. Number 2, this is a 40-year-old male, body mass index of 45. He's sent in from his orthopedic surgeon. So nowadays for knee replacements, if your body mass index is over 40, the surgeons don't want to do surgery on you anymore because there are more complications, and they're now responsible for those complications. So they want to get your weight down. So this is a common referral to weight loss centers. Needs a knee replacement. In the past, he was on phentermine, but it caused insomnia and palpitations, so his heart did a little bit. That's uncommon, but again, possible. He has sleep apnea, and he uses CPAP. He has high cholesterol, metabolic syndrome, which is really pre-diabetes. His hemoglobin A1C is 6.3. So in the diagnostic criteria, if you're over 6.5, it's diabetes. If you're between 5.7 and 6.5, it's pre-diabetes. If you're 5.6 or less, you're normal. So he has pre-diabetes, osteoarthritis, probably of his knees and or his back. He has high blood pressure. He has excellent insurance. For him, he's already on atorvastatin, which is Lipitor, a cholesterol drug. He's on metformin for his diabetes, and losartan, which is a blood pressure medicine. Very commonly used in a lot of people. Medical management is definitely something for this person because he needs to lose weight to have his knee replacement. Weight loss in this gentleman, because of all the things, he has a high BMI, he has sleep apnea, he has insulin resistance, and he's unable to take one of the simple drugs, which is phentermine. So what do we do next? Liraglutide is a very good choice in him. High weight loss, reverses metabolic syndrome. It's a non-stimulant. It reduces his, so this is an interesting thing. In some study, it was shown to reduce the apnea-hypopnea index, AHI. So when you have sleep apnea, the amount of times that you stop breathing every hour is called your apnea-hypopnea index. Normal would be less than 5 times in an hour, and there are people that have 100 times an hour or 60 times an hour all the time. So 60 times an hour is once a minute, or 30 times an hour is once every 2 minutes. And so it decreases his apnea-hypopnea index by itself. We don't know the mechanism through that. High odds of 5 and 10% weight loss. Expensive, but he does have insurance that covers it. Lorcaserin is another choice. Lower weight loss, non-stimulant. A little lower odds of 5 and 10% weight loss than the liraglutide or Saxenda, but it is less expensive. And diethylpropion would be another one to consider in him because he had problems with phentermine. Diethylpropion doesn't have those same problems. Last few, Contrave, another possibility in him, but the problem is when he has his knee surgery, he's probably going to need a narcotic pain-based medicine for his knee for a while. And so he could use it now to lose the weight. We'd have to stop it for the surgery. And last is the phentermine with topiramate. Because it does have lower doses of phentermine, if nothing else worked, it would be another option for him, or the two separately. I think this is my last person. This is another 56-year-old, or a 56-year-old male, body mass index of 43. He had a lap band 6 years ago. He has type 2 diabetes, bad enough that he's on insulin. He has chronic renal insufficiency, so his kidneys are not working. He has 60% of the kidney function he should have. He's had an abnormal echocardiogram and abnormal EKGs, so his heart's not normal. He's starting to develop congestive heart failure. This is a sick gentleman. He has 6 medicines for blood pressure. 6. That's up there. His sleep apnea is not controlled. He's on insulin at 50 units of glargine, which is the long-acting one. He's on Lispro also, which is a short-acting insulin. Pioglitazone is another diabetes medicine. Clonidine, valsartan, furosemide, which is Lasix, metoprolol, minoxidil, and amlodipine are his blood pressure medicines. His hemoglobin A1C with all that is 6.8. So it's okay, but it's at the top end of normal. His creatinine is 1.2, where it should be less than 1.0. That's his kidney function. And so this was to doctors. How would you treat this patient? Anybody? So he's already had the gastric band. The nice thing about science is we learn, and the lap band is not being done almost anywhere in the US any longer. There's still some centers because it doesn't have good long-term data. By 5 and 10 years, 50 to 100% of the people have taken their lap band out because of complications and problems and lack of weight loss. He does have life-threatening weight problems. If he continues on, he will not live very long. Chronic renal insufficiency, congestive heart failure, and hypertension. He is a high-risk person. He has type 2 diabetes on a significant amount of insulin. His weight loss is going to be challenging, yet it's going to help save his life. He has an abnormal EKG, so we have to remember to keep that in mind as we treat him. So what do? He did a full meal replacement plan. Weaned his insulin by half on day number 1 because of his full meal replacement plan. He started Lorcaserin, that's the Belviq, at 10 milligrams twice a day. He isn't a good candidate for phentermine because of his heart, diethylpropion for the same reasons. He's not a good candidate for the phentermine topiramate because of, again, his heart and his kidneys. He's not a good candidate for liraglutide because at this time he's on insulin and you can't use the two together. And he's probably not a great candidate, or maybe is a candidate for the Contrave. So in 2 weeks, he was down 5 pounds. He was feeling well on his Belviq and on his food plan. By then, he had stopped his insulin. He was able to stop it completely. 2 months later, he was down 26 pounds. His cardiologist took him off or decreased by 50% 2 of his 6 blood pressure medicines in this amount of time already. His sugar, despite now no insulin, is in the 120 to 140 range. I think he would have loved to have these numbers 2 months prior. He's researching now liraglutide because he's now off of his insulin. So now potentially a stronger medicine for him, more potent, but couldn't take it before. Neat studies and what you can do with weight loss medications. When the new generation of weight loss medicines came out, the FDA, so I mentioned that there was Xenical that came out a while ago, and there was another one, I'm completely blanking on the name of it, but Meridia. I don't know if anyone took Meridia. So Meridia went off the market in an interesting study called the Scout study. And what they found in that study is if you lost weight, it was a great medicine. Because it did cause some people's blood pressure to come up a little bit by being on the drug, but as soon as they lost weight, the benefits of losing weight helped them. But the people who didn't lose weight had the complications of now having the mildly higher blood pressure. So they said, well, if you're not losing weight on these drugs, we probably should stop them. And so they all now, the new ones, have recommendations that if you don't lose a certain amount of weight in a certain amount of time, you're not getting the benefit. Don't stay on them. So way back, phentermine and diethylpropion, long before those kind of rules existed. So we don't have recommendations. On phentermine with topiramate or Qsymia, if you don't lose at least 3% weight at 3 months, the recommendation is either to stop it or build the dose, because there's those 4 doses. So usually someone is at the 2nd dose, and now you build up to the 4th dose. And then you get another 6 months or so, and if you haven't lost at least 5% of your weight, then it's recommended this is not the drug for you. Lorcaserin is 5% at 3 months. If you don't get 5%, again, you're not responding to it. Now, all these drugs have what we're going to call super responders. The same person, if it averages 20 pounds, there's someone who's going to lose 60 or 80 pounds. And then there's going to be people who gain a few. I'm going to talk about that in one slide as we come up. Naltrexon and Bupropion, which is the Contrave. You want to lose 5% by 3 months at the full dose, but it does take 4 weeks to get to the full dose. So you have to take that into account. And then liraglutide, the last one, that one's It's usually 5% is the one we look at. This one is a 4% at 16 weeks. It takes 5 weeks to get to the full dose. Phentermine long-term use. So as I kind of said, it came out in 1959. The belief was you'd take it for 12 weeks, you'd cure your weight, and it wouldn't be a problem. So a lot of people have said, we don't have studies directly on phentermine, and we would probably, unless the government decides to do them, no drug company on a generic drug since the 50s is going to do the studies. We do have phentermine with topiramate, so Qsymia, that shows 1 year, and I think we have even more than that data showing that it's safe. And then it's come out as kind of a belief that we've been using this for 60 years now. There's good case reports of the same person using it in over 10 years, and we have not seen any problems. And so because it's used millions of people a year for years at a time, and we haven't seen any signal of problems, we pretty much are just gonna have to accept that it's a pretty safe drug. When you use medications, medicine, as we talked about the 4 legs of the chair, you need to put more legs together. So sibutramine was the one I talked about that went off the market, or Xenical, not Xenical, Meridia, thank you. And so if you were on it, you lost a little bit. If you did lifestyle modification alone, you lost a little bit. If you did sibutramine with brief therapy, you did a little bit. But if you combined it all, sibutramine with stronger therapy, what happens? More weight. So another one, drug alone is the first one. Drug plus lifestyle, the second one. Combine all of it together, more weight loss. The more things we do, the more legs of the chair we use, the better weight loss we get. This one was done on Lorcaserin or Belviq. This curve right here is placebo, people who didn't lose any weight. The first part of this curve up until here are the people who are on Belviq. They lost a lot of weight. Then at this point right here, some of them were actually told, just go off it. Cold turkey, don't take it anymore. And what happens, we know when you stop weight loss drugs, they go right up and they meet the other people who never took the drug. Now the people who were on it still started gaining some weight, but not as much as the others. And that's when you talk about what are you doing with your diet at that point? Are you adding other medicines in at the same time? Is your exercise staying together? Is your sleep staying together? And all those other things are not studied in studies. Everything else is controlled evenly. This is one of my favorite types of charts that I'm going to tell you is not done in weight loss. So this is called a waterfall plot. Each one of these little things is a person in a study. So if there's 100 little lines, there's 100 people in the study. And what it's showing you, and this isn't any particular study I want to show you, but it's showing you in the same treatment, pick any of the drugs I've talked about, any diet we talked about, there are some people who lose a lot of weight. And there's some people who lose a medium amount of weight. And there's some people that only lose a very little amount of weight. There's some people that lose no weight. And what do we see here? There's people that gain weight in the same studies. And so what does that say? We're all different. On the inside, the genetics that's causing our weight problem is different. And so if we talk about starting one medicine and we don't see the effect of it, what do? We change. We change to something else. If one diet doesn't work, we change to the other. If one exercise isn't making you happy, we change to the other. And unfortunately today, and I think for the next 10 years, we don't have the genetics that are going to be able to say, like 23andMe, I'm going to swab the inside of my throat or my cheek, I'm going to send it off, and 3 weeks later I'm going to get a result that says I should use this medicine, and I should sleep this much, and I should do cardio 3 hours a day, and so forth. Currently, the tests exist, but they don't tell you anything. And so the last time I was at a conference, one woman who did research on this was her published study, she did the swab, and it sent her back, and it said, eat less fast food, do cardio, and you should be on a diet. It was like, really? I had to do a swab for that? And that's where we are today. It's not where we're going to be eventually, but it is unfortunately where we are today. And so it's educated guess, it's listening to all the other things that people have going on. Do you have migraines? Do you have blood pressure problems? Do you also have knee problems? All those little things, and kind of an art and a science to figure out what we need to do. That's weight loss drugs. Questions?
If you've got diabetes and you lose weight,
yes,
and you get your A1C below the 6, Are you able to then go off the medication metformin, or do you have to stay on that?
So there's always a debate in that. My belief is if the medicine helped you get below your 6, why don't you just stay on it? So some people will do that. Others will say, well, let me try off of it. If my weight starts going up or my hemoglobin A1C comes up, let me go right back on it. Metformin is a really well-tolerated, inexpensive, used for years in people drug. To me, that's one that we should keep. Now, if you're on something else that caused you potential side effects or you were noticing, but you're like, I'll put up with it, then we should stop it and see how it is. Yeah. The question then comes up to take it one step further. Once your hemoglobin A1C is under that, do I still have diabetes?
That's my next question.
And so I think the answer is, at that particular weight, no, you don't have diabetes. But if you regain your weight, your body will take over what it used to do, and then it's the same thing again.
Is probiotics taking the, I know it's not a weight thing, but does it help or harm? Or?
The 5 doctors in our practice get together every month, and we have a little meeting. And we have a little journal club. So we all pick an article to review. And so I actually just reviewed one on probiotics.
Good.
And I think the answer is we don't know. There are definite reasons to take probiotics. I think probiotics have gotten this, they're great for everything. And I think the answer is they're not great for everything. In certain times when you take probiotics, after you take antibiotics and such, it takes longer for your normal bowel bacteria to grow back to normal when you're taking that, because you're kind of feeding one type, and we have billions of bacteria in our colon. So the answer is, I don't know. That's truly what the answer is. There are certain indications that you should take it. If you have something called C. difficile colitis, and they give you antibiotics for that, it has been proven that probiotics definitely help. For other reasons, I can't say yes and I can't say no. There is no verdict, unfortunately. So for a lot of people, I'll say try it for a month. If you think it does something, stay on it. If you don't think it's doing anything, don't. Other questions?